Hello and welcome back. This is part 2 of cardiac pharmacology for NUR 200. And in this video, we're going to look at some antihypertensives, the renin-angiotensin-aldosterone system, and if we have time, we're going to get into the adrenergic system with your beta blockers and some of your other blockers. But before we start that, let's go over some terms that are important and that you'll probably see in clinical practice. The terms chronotrope. Okay, chronos is Latin for time, and medications that are chronotropes are medications that are going to affect the heart rate. Okay, dromotropes are medications that are going to affect electrical conduction. And inotropes are probably the most familiar ones to me because you see that terminology a little bit more often. And inotropes are medications that are going to increase contractility of the heart. Now that we have that down, let's look at medications for hypertension. Hypertension is an epidemic in the United States, much like diabetes. And so you're going to have patients, if you take care of adults, who are taking medications for hypertension. Okay, lots of things go into why blood pressure is elevated. One thing is blood volume. So fluid loss or dehydration is going to bring a blood pressure down. Fluid retention is going to increase the blood pressure. Two different hormones that affect fluid retention are aldosterone, which will be coming up shortly, and antidiuretic hormone, which you guys know all too well from diabetes insipidus and SIADH. The second thing that goes into blood pressure regulation is peripheral resistance, or the diameter of the arterioles. Other places you may see this referred to as systemic vascular resistance, or SVR, or you may also see it as afterload. And you'll see that afterload is actually in the third column as well. Things that affect the diameter of your arteries and your arterioles are your sympathetic nervous system. You know, when your fight or flight response gets stimulated, you're going to expect that you vasoconstrict so that your body gets enough pressure in order to give you the energy that you need. The renin, or the angiotensin II in the renin-angiotensin-aldosterone system, is a potent vasoconstrictor. And increase in blood viscosity can also increase your peripheral resistance. The third thing that affects your blood pressure is cardiac output, which is the amount of blood ejected from the heart in 1 minute. And it's heart rate times stroke volume. So stroke volume is the amount of blood ejected in 1 beat. Things that affect the amount of blood ejected in 1 beat are preload, which was one of your terms that you had to learn for your pre-assignment, contractility, and afterload. Okay, afterload is the force the ventricles have to pump against, also known as systemic vascular resistance. Things that affect the heart rate are the sympathetic nervous system, the parasympathetic nervous system, and if anybody's gotten woozy and starts to what they call vagal down, you know all about your parasympathetic nervous system. And epinephrine. Epinephrine is this lovely thing that is your fight or flight response. Moving on. Other factors, emotions. Anger and stress can affect your blood pressure in a negative way. When I was finishing my doctorate, my blood pressure was trending upwards. Now that I'm done, I'm hoping my blood pressure starts to trend down. Okay, some corticosteroids can affect your blood pressure because if it affects aldosterone, you're going to have fluid retention, which is going to increase your blood volume. Smoking. Think about what smoking might do to blood pressure. Why might it increase blood pressure? And I'm just going to let you think about that rather than answer the question for you. Okay, knowing what nicotine does and the different things that smoking does, the effects it has on your cardiac system, I bet you can reason it out. Guess what? Lack of sleep can give you high blood pressure. So for those of you that like to cram, and I stopped doing that in my 20s, stop it, okay? Because it'll lead to hypertension. It's better to get a good night's sleep and your brain is rested. And some of it's genetics. Once again, genomics and genetics come into play as one of those non-modifiable risk factors that will contribute to your health history. Your primary antihypertensives, generally they will move in a specific logical progression. Not always, because I haven't seen that necessarily, but Generally, it calls for diuretics first, and specifically thiazide diuretics. Oftentimes, if I see a patient on hydrochlorothiazide or HCTZ, I think about that was probably prescribed for hypertension. You might see furosemide, but more often than not, hydrochlorothiazide is your first line of defense. And think about what a diuretic is going to do to lower blood pressure. Okay, going back to that diagram with the three different things: blood volume, peripheral vascular resistance, and cardiac output. So diuretics are going to affect what? If you said blood volume, you're correct. Okay, ACE inhibitors. Okay, your prills. Okay, renin-angiotensin-aldosterone system, which of course I've told you in class is one of my favorite things. Primary goal for the renin-angiotensin-aldosterone system is to increase blood pressure through two different mechanisms that we'll talk about. Angiotensin II receptor blockers, or ARBs, okay, work in the same system but a little bit differently. Beta adrenergic antagonists. Remember, an antagonist is a blocker. So what I'm saying here is beta blockers. Calcium channel blockers, and there's also direct vasodilators. And what they find is two antihypertensives have a synergistic effect. Okay, if you don't know what synergy is when two things work together and 2 + 2 becomes 5. In other words, they amplify one another and they work better together. There's a lot of combination drugs out there on the market. So when you're giving medications in clinical, you may see something that has, for example, hydrochlorothiazide along with a vasodilator. So keep an eye on that. So the diuretics, first thing, thiazide diuretics are your first line for mild to moderate hypertension. Hydrochlorothiazide, HCTZ, it is a potassium wasting, so your big risk is hypokalemia. Your potassium sparing diuretic can also be used, aldactone. With that, you have a risk of hyperkalemia. And when we talk about Cushing's and Addison's, we'll dig a little bit deeper into why that is. Loop diuretics, going to give you some greater diuresis, but once again, is a risk of hypokalemia. All are going to reduce blood volume by excreting water and electrolytes such as potassium, calcium, sodium, and chloride. And you guys are pretty familiar with diuretics. Thiazide diuretics, the hydrochlorothiazide, decreases the reabsorption of sodium and it increases the amount of urine produced, therefore decreasing blood volume. And like I said, a lot of times this may be your first line of defense. Relatively cheap, and usually will teach the patient to administer early in the day to prevent, nocturia. And sometimes what you'll find, depending on the population, in a geriatric population or an aging population, is if a patient has plans or a client has plans, they're going to hold their diuretic because they don't want to be getting up and going to the bathroom all the time. Or if they're taking a long car trip, they're going to want to hold their diuretic. So you do need to do some teaching with them in terms of how to plan that into their day so that they're still treating their hypertension and not ignoring their health. It is an inconvenience for a lot of folks, and especially as you get older, your bladder and your bladder control changes. So it can be a problem for patients to stay adherent to diuretic therapy. So sometimes they'll move on to other things. Your prototype loop diuretic you're all familiar with, and it's furosemide, also known as Lasix. Lasix is the go-to when you want to remove a large amount of fluid in a short period of time. The half-life is 30 to 60 minutes. When you give it IV, it's going to come on, its onset is going to be 5 minutes, so it happens very quickly. Duration, if you give it PO, is about 6 to 8 hours. Also an important thing to cover with patients when you're discussing medication compliance, because if they know that they're going to have to urinate for 6 to 8 hours, then they may not take their medication when they need to. Its mechanism of action is preventing the reabsorption of sodium and water in the loop of Henle, and it's very important to check the serum potassium before administering the drug due to the potential for hypokalemia. And this is very important. If your patient has a potassium of 3.2, you don't check you administer Lasix. The potassium drops to 3.0, and the next thing you know, they're coding in a VTAC or VFib arrest. They're going to look back at you and ask you, didn't you check before you gave it? So I cannot stress the importance enough of monitoring potassium. Adverse effects, you know, the fluid and electrolyte imbalance, and the other thing is ototoxicity. You never want to push Lasix too fast because it can cause ringing of the ears. Nurse's role in diuretic therapy: assessing renal function, monitoring your electrolytes and your vital signs, I&O, and daily weights. Daily weights are very important when you're looking to see what did the diuretic do. If you ever get a question on the NCLEX or on an exam that asks you, how do you know if it was effective, you look back to why you gave it. So if you gave something for hypertension, effectiveness is going to be measured by a decrease in blood pressure. If you gave it because of CHF, you have to look to see, were you given lung sounds or were you given an increase in weight in the question? And that's going to be your effectiveness of your drug. Aldosterone, you don't want to forget, and it's coming shortly. So let's get started on ACEs. I don't know that we'll finish it in this video. I may have to continue it in a further video. But ACEs are your renin-angiotensin. They affect your renin-angiotensin-aldosterone system. ACEs are primarily used for hypertension and congestive heart failure. I'm going to skip over to something really quick. Not this one, this one. This is going to be posted in Blackboard, and it's a blank renin-angiotensin-aldosterone system. If I don't get a chance to go over it in class, I'm also going to give you the one with the blanks filled in. And what it is basically a visual of how the renin-angiotensin-aldosterone system works, starting with a decrease in blood pressure causing a renin release from the kidneys. So I will make sure that this is posted so that you have it to refer to, and hopefully we'll get a chance to go over it in class. Back to your ACEs. Low blood pressure, kidneys don't like it. So they're going to release renin. Liver is going to be producing angiotensinogen. Renin converts angiotensinogen to angiotensin 1. Angiotensin converting enzyme is going to convert angiotensin 1 to angiotensin 2. Once you have angiotensin 2, it in and of itself is a potent vasoconstrictor, which is going to increase your blood pressure. But wait, I'm not done yet. It also causes aldosterone release from the adrenal cortex, which is going to increase sodium reabsorption and water reabsorption from the kidney, and increasing blood pressure by increasing blood volume. So what we're going to do is we're going to block this angiotensin converting enzyme. So if that is blocked, then this system will stop right here. And you won't have the vasoconstriction from angiotensin 2, and you won't have aldosterone release. Primary use, like I said, is hypertension and also for congestive heart failure. It's very important to monitor for side effects, and I believe they're on the next page. So let's look and see. Okay, not yet. But the prototype is ending in pril, enhancing excretion of sodium and water to decrease blood pressure. Usually with your first dose, you worry about hypotension. Okay? You worry about cough. Okay? A dry cough is very common with patients who are on ACE inhibitors, and sometimes it's enough to make them want to go off of the therapy. There's a big risk of hyperkalemia, so you have to watch if a patient is taking aldosterone and a pril, because then you have two medications that are going to possibly cause hyperkalemia, and you have to watch that. Another big one is angioedema. I'm hoping that is coming up soon. One thing to think about, like peanut butter and jelly, anyone with heart failure should be receiving an ACE inhibitor. Certainly those of you who are doing clinical on the heart failure unit are seeing that now. That's part of their clinical practice guidelines, is to ensure that their CHF patients are on an ACE inhibitor. Your role? Assessing blood pressure, both before and after. Okay? It's not just us being annoying in clinical. We want to know the blood pressure before you give it. Assessing kidney function. Assessing for hyperkalemia, and if the patient starts complaining of their lips and their throat swelling, you have to worry about angioedema. You don't want to give salt substitutes because they have potassium.